All right. Can y'all hear me now? Yay! Thank you. Who said that to me? Rachel, thank you. I'm not very IT/tech savvy, so I really appreciate that. Okay, let me just see. Let me admit a few more people in here and then we will get going. Right. Okay. If there's some more stragglers that come over, we'll add them in and include them. But first, just to introduce myself, my name is Dr. Rachael Haverland. I am owner of Endometriosis Center of Excellence here in Dallas. But I will say that, you know, half of our patients come from out of town. They're coming out of the DFW Metroplex. Today, I met with a patient from New Mexico, Louisiana, Arkansas, California. It's just really neat to see this endometriosis community. Um, and just to treat and learn from you guys more about endometriosis and to advocate for endometriosis. And so really, this is what these webinars are for. These webinars are for advocacy, to learn more about endometriosis, there's a lot of things we don't know about endometriosis, but trying to educate ourselves. And I try to educate my patients so that they can teach other people, other providers, other patients about endometriosis. So today, for the next hour, we're going to talk about kind of the biology and etiology of endometriosis. So understanding the biology and etiology of endometriosis. So the goal is to finally understand what endometriosis really is. Why is it more than just bad periods? I mean, we hear this all the time. Oh, you have bad periods. My sister had bad periods. My, aunt had bad periods. Well, endometriosis can present it that way, but most of the time it's much deeper than that. It's a whole body inflammatory disease. And so we're going to kind of dive into the underlying etiology of endometriosis. So many women live for years with symptoms like painful periods, bloating, fatigue, gut issues, and they never know they can all be connected. Frequently, endometriosis is the underlying cause. This webinar reveals what endometriosis actually is, how it starts, why diagnosis takes so long, what's known and also what's unknown about its root causes. Endometriosis is devastatingly underserviced when it comes to education and research. We have very little funding for our research, women's health in general, but especially when it comes to pelvic pain. Most of the funding in women's health, a lot of it goes to fertility aspects, which is also very important, but endometriosis is sort of left behind. And so while there are many things that we know about endometriosis, there's also many things that we don't know about endometriosis. So by the end of this webinar, you'll understand how endometriosis forms, what causes it, and what that means for your health journey. So if you've ever felt brushed off, confused, or just plain exhausted by doctors not taking your symptoms seriously, this is for you. I'm going to add a few more people in here, and then we will jump right on in. All right. So one thing I'd like to mention before we really get started is I would like this to be interactive as much as I can. So y'all use this chart feature, message me, ask me questions throughout it. I want to know what questions you have, because sometimes I just get going and I can talk for hours about endometriosis. I'm very passionate about endometriosis. I feel that this affects so many women, and I feel honored that my patients share their stories with me. I mean, these are very intimate details of their lives that they're sharing with me, rather, episodes that affected their daily functioning, pain that affected their relationships or their fertility. And I'm so honored that I get to share in these stories with you guys and that you share them with me. But throughout the next hour, please use that chat function to message me questions if we go through something that doesn't make sense or that you have more questions about. I'm happy to try to answer some of those questions as we go along. And then I won't feel like I'm talking to myself for a whole hour, so that I get a little bit of interaction that way too. All right. All right. So let's get going into kind of dive into endometriosis. And, you know, I talked about this earlier. If you've ever felt brushed off, confused, exhausted by endometriosis, doctors not taking your symptoms seriously, this webinar is for you. Today, we're going to learn more about endo, the underlying etiology. And at the end of this, you may know more than some of the doctors do about endometriosis. So the goal is to do this without confusing jargon or assuming that you've had a medical degree, just real explanations that finally make sense to you, the patient, because you're the one living it. So you may have heard the word endometriosis, but what does it really mean? How does it explain all the strange symptoms you've been experiencing? So on average, it takes women 7 to 10 years to be properly diagnosed with endometriosis. That's a decade of suffering and silence. And that is so frustrating. So I am Dr. Rachael Haverland. I'm a board certified endometriosis excision surgeon. I have advanced training in endometriosis care. I did a fellowship at Mayo Clinic with endometriosis excision. I've been vetted through I Care Better. I submitted videos to show that I have advanced training in difficult endometriosis cases. I also have given my credentialing and my case list to the hospital. So I am a endometriosis surgeon of excellence at my hospital, and I do all of these things not to have another thing on my wall, but to show patients the precision and the care and the skills that I have, so that I'm trying to show you that we can do this safely and we can do this appropriately, so that you can have a better quality of life, and so that we can treat you so that you ultimately see improvement. So my job here is to explain what your symptoms are really telling you. So you'll leave this webinar understanding where endometriosis comes from, how it works in the body, and what that means for your next steps. So at the end, stick around and I'll send you my endometriosis origins and symptoms checklist. It's a free download. So if you make it to the end, we'll kind of go through all the checklists and review that together as well. So there's a misconception about endometriosis. It's just tissue growth where it shouldn't be, right? So there's a misconception that endometriosis is just the endometrial lining that is implanted elsewhere. And so I want to kind of go into some of these like leading theories of endometriosis, because the cells of the endometrium are very different than the cells of endometriosis. So while they are the closest things that we can find under a microscope that look the same, they are also very dissimilar. They're dissimilar in their underlying cell lines. Some of the genes are more expressed than others. And there's many things that we do know about endometriosis and how it is expressed, but there's also many things we don't know. So the leading theories of endometriosis, one is retrograde menstruation, and that has been really, it's a frustrating theory, because I think one is it's not well proven. That I've had patients that have not yet had a period have endometriosis. I also have postmenopausal patients that are no longer having menstrual cycles that have showed they have endometriosis. At least 70 to 90% of women during their period have retrograde menstruation. So that theory doesn't really hold true, because 70 to 90% of women do not have endometriosis or pelvic pain. And so the retrograde menstruation theory is actually very devalidating for women. And so we do not think that is accurate. So there's another one with immune dysfunction. So these cells of the endometriosis, they have different cell lines. So some of the cells that they express more, some of the gene receptors that they're expressing are showing more cytokines, which are inflammatory. T cells are also inflammatory. There's some of the cells that our body uses to fight infection or inflammation. And so the immune properties of the endometriosis can be different. There's also some theories of it's called benign metastasis. So how cancer metastasizes throughout the body, it follows some of the lymphatic channels. So when you have uterine cancer, for example, there's specific lymph nodes that you check to see if it is spread. Endometriosis may spread similarly. So I talk to a lot of my patients about how endometriosis affects the appendix. And they're like, well, why does it affect the appendix? It's more common if you have a right endometrioma or more deep infiltrating endometriosis disease on the right side of the near the appendix, but it's also just not in proximity. There's kind of some lymphatic spread that goes in a circular motion. And ultimately, we think that that may be why some of the endometriosis is more likely to spread to the appendix. But as you can tell, there's a lot of theories about how endometriosis spreads without actual knowledge. And to be honest, it's probably a combination of many of these. So I had a patient, she just a few weeks ago. Um, she was talking about how she had whole body inflammation, and she came in and she's like, honestly, I don't know if this is endometriosis. You know, my acne flares, I feel bloated all of the time. I have hypersensitivity to foods more so than other people that I know. Not necessarily celiac, but there's a lot of foods that I can eat that I'm sensitive to and I have a reaction to. I also have these other comorbidities that are related to like rheumatoid factors. She's like, and I think it may just be all hormonal. And at the end of the visit, we went through all of her symptoms. And it's like, you know, this frequently is related to endometriosis. Endometriosis is very much a whole body inflammatory disease. Even though endometriosis technically isn't considered autoimmune, frequently it's associated with other autoimmune diseases. Like rheumatoid arthritis, Hashimoto's, thyroid diseases. So a lot of other comorbidities are also associated with endometriosis. This immune response that we're talking about, how the cells of the endometriosis display their genes differently. And so understanding why endometriosis happens helps you take control of how it is treated. You have to understand and sometimes remind your providers that this is a whole body inflammatory response. It affects everything from your head to your toes. I have patients that tell me, I have knee pain. I have joint pain. It's not just in my shoulders, it's in my knees, it's in my toes. Is this related to endo? And it may not be endometriosis implants in your knee or on your foot, but this whole body disease, this whole body inflammation, absolutely can affect you that way. And so it's really important to kind of have a grasp of how this endometriosis is affecting us in these different ways so that we can learn to treat it. So there's the next is I want to kind of talk about genetics, risk factors, why diagnosis takes so long. So there's a misconception that if it was serious, my doctor would have told me already. You know, I can't tell you how many patients have gone to see doctors and they're telling them, you know, I've had painful periods, or I have bloating, I have bowel pain, I have bladder pain, I have pain with intercourse, I'm having trouble getting pregnant, over and over. Rather the same doctor, or they're sent to multiple specialists. Go see a GI doctor, go see a urologist, go see another gynecologist. Maybe you need to see a hormone specialist. But then ultimately it's all tied to endometriosis. And finally, somebody says the word endometriosis, and then the patients start to educate themselves and realize that a lot of these things are all tied together. So I want to talk next about hereditary links and why patients get so many diagnostic delays, why symptoms often gets misled as IBS, UTIs, interstitial cystitis, or anxiety. That's my least favorite one. Is patients, they're coming to the hospital and they're like, oh, it's all in your head. It's histrionic. It's anxiety. It is not. I actually have a shirt that says that. It is not in your head. It is in your pelvis. And I try to be an advocate for women that are having, kind of fighting this uphill battle. All right, I'm going to answer a few questions on the chat. So again, I appreciate you guys using the chat. That way I don't have to talk to myself directly the whole time. So we talked about some of the autoimmune properties that are associated with endometriosis because it is a chronic disease. Your body is fighting this inflammation. One of the most common symptoms of endometriosis is fatigue. And I tell patients this all the time. I read through this study that talked to me about fatigue. I was making a PowerPoint for a presentation. And at first I was kind of annoyed. I was like, well, this doesn't help me at all. Patients that are fatigued, everybody is fatigued, but it makes so much sense. Your body is chronically fighting this disease and just trying to stay afloat, trying to function. So it gives you very little energy for your daily functioning or anything outside of that. People are like, I'm so tired. I'm sleeping 8 hours a day. I'm taking naps. I'm running around after my kids, or I'm going to work. I literally can only do the bare minimum. I have nothing left in the gas tank. And so that's how endometriosis affects you. It's also kind of breaking down your immune system. And so your body doesn't have a lot of energy. Some women feel like they're sick more frequently, and it may be because the viruses have more effect on them. It also may be because their body has nothing left to give, because it is affecting their ability to actually fight diseases. All right, so again, going into the side. So this patient, Lorena, said it took her 9 years to be diagnosed with endometriosis. That is unfortunately incredibly common. My goal in my practice is to treat women early, try to catch the disease where it's still stage 1 or stage 2 disease. So you have a much better chance that it doesn't recur, better chance that your symptoms improve, better chance that it doesn't affect your fertility down the road, and gives you that ovarian preservation. So ovarian preservation is so important, and I feel like we don't talk about it enough, but endometriosis, excision, and removing the endometriosis is important for preserving your fertility and improving your pain, but also the ovarian preservation. The ovaries have a lot of longevity benefits for us as women. They protect our bones, they protect our heart, there's some cognitive protection with our ovaries. There's so many benefits we don't even know. There's plenty of studies out there showing that the natural hormones our natural estrogen give us benefit, and we don't even know why, because technically what we're making under the microscope to give back to women is very similar to the same estrogen, but it's just not as good. And so preserving those ovaries for longevity by removing the endometriosis so that the ovaries function better is also very, very important. And I am so sorry that it took you 9 years. The earlier we can treat, the better. And I do very much believe in a multidisciplinary approach. And that's what we talked about last time. We talked about, physical therapy with a good pelvic floor physical therapist. We talked about diet. We talked about exercise. We talked about acupuncture. Hormones do play a role, for treatment in some women, especially with concomitant adenomyosis. Not everybody has to have hormones, of course, but I do think it's important to know all of the options, especially when it comes to the adenomyosis. Somebody said they had surgery with me yesterday. That's awesome. I'm glad you're here. I can't believe you're on the webinar. Yeah, and this patient talked about being on birth control to try to help with some of the inflammation, and it certainly can be beneficial. Some women can't tolerate birth control, risk of blood clots or mood changes that affects their mental health with depression or anxiety. Other people see weight gain or it doesn't help their pain. I have a lot of women that try it and their actually pain gets worse, or they start to have irregular bleeding. But for some women, birth control absolutely can help with the hormones to try to suppress some of this inflammatory response of the endometriosis. It does not make the endometriosis go away, but it can help with some of these inflammatory cells of the endometriosis. So now I want to, here's a great question. When did excision surgery begin? I had ablation 7 years ago, and I'm wondering if that was available. So most OBGYNs are not trained in excision surgery, unfortunately. In residency, most of our time and commitment is given to pregnancy and obstetrics, which is very important. You have two patients at the same time. It's women's surgery. Women's bodies change dramatically during pregnancy. It's very high acuity. But we get very little training in surgery. Most OBGYNs are not trained in surgery. So the doctors that are able to do excision surgery typically have performed or completed a fellowship. So I did my GYN fellowship at Mayo Clinic. with kind of some of the pioneers of endometriosis excision surgery. Dr. Javier Magrina was one of the first ones starting to do this surgery, where he could actually go in and excise the disease. He's a trained oncologist, and he does not practice anymore, but he still does plenty of lectures, and he's very well known in the endometriosis community. But he probably started doing endometriosis surgery about 15, 20 years ago, but I will say that he was one of the only ones doing it. When I went through residency training, I also had another mentor, Michael Hibner, who was doing endometriosis excision surgery. So I was exposed very early. But I still think there's a very small subset of OBGYNs that feel comfortable doing excision surgery because it's technically more difficult. It carries more risk because you have to dissect out the ureters and the nerves and some of the blood supply. So it's important to keep some structures safe and then make sure you're able to remove the endometriosis completely, because if you leave endometriosis behind, you're not getting the benefit. So I would say probably 10 years ago, it became more common, but there's still a very small subset of doctors performing excision surgery because of the technical difficulties. Okay, so one thing I wanted to mention in the chat, there is a link that you can use to book a phone call with my scheduler. So I have a lovely woman answering my phones. Her name is Cyrus, and she's excellent. So this will help you get in touch with her, and then she will help you book an appointment. So this appointment will help you. Once you meet with her, you'll be able to make an appointment with me. Usually it's just a phone call, and she'll be able to get you in touch. You can also call the office. There's a lot of different ways to get a hold of us, but make sure if you'd like to have an appointment with us, you click on this link that's there in the chat. All right, so I'm going to go back to kind of the basics, because I went off on a tangent talking about why it takes so long to get diagnosed. But next, I want to talk about hereditary links of endometriosis. So I think this is one of the most interesting parts of endometriosis, because endometriosis, I've told many of you, it doesn't follow the rules, and so sometimes it's very difficult to anticipate. Stage of endometriosis does not correlate to symptoms. So I have women with stage 1 disease that are just debilitated in pain. I have other women with stage 4 disease who actually are quite asymptomatic. Their only symptom is that they have trouble getting pregnant, for example, or maybe just painful intercourse, but the rest of their time they're asymptomatic. And so that's one of the reasons why endometriosis is difficult, is not everybody fits in this little box of symptoms. Some people have every symptom of endometriosis. They have painful periods, they have painful bowel movements, they have constipation, they have bladder symptoms. Other people may only have 1 or 2 of these symptoms, and so it does make it a lot more difficult. So hereditary links. The strongest link is between a sibling. So if you have endometriosis and your sister has similar symptoms, her risks or chances of having endometriosis increases 8 to 10-fold. Of course, twins is the highest hereditary link, but siblings is the highest. Next would be a first degree relative. So if your mom has endometriosis, that would give you an 8 times increased risk. So endometriosis is already 1 in 10 women. It's likely much higher than that, but that's what the statistics show, but likely more than 1 in 8. But then with a first degree relative, your chances of endometriosis increase 8-fold. And so when I hear this, from a patient, they're telling me, well, my mom had endometriosis, my grandma had endometriosis, my aunt had endometriosis, my ears perk up and I take them seriously. Women with a family history of endometriosis where there's some genetic link tend to be more aggressive subtypes of endometriosis. So these are the women that are more likely to have stage 4 disease, advanced endometriosis, deep infiltrating endometriosis into their colon, into the pelvic sidewalls, affecting their nerves and their ligaments and some of these other organs that sometimes aren't as affected by endometriosis. But women with a genetic predisposition to endometriosis certainly have a higher risk factor for deep infiltrating disease, more advanced, more aggressive subtypes of endometriosis. And so And then with a second degree relative, your risk increases sixfold. So sixfold with second degree, eightfold with first degree, 8 to 10-fold with a sibling. So if a patient comes into me with these symptoms, and then I ask them if they have a family history, endometriosis sometimes is difficult to diagnose because we don't frequently see it on imaging. Many times you get normal ultrasounds or normal MRIs, which can be quite infuriating, at least to me, because I feel like it devalues your symptoms. But until endometriosis is more advanced, stage 3, stage 4, many times we don't see it on imaging, and sometimes we still miss it, when it gets more advanced. And so it is incredibly important to listen to your patients, listen to their symptoms, listen to their history, know what to look for. That's how you're going to get an accurate diagnosis. I am a surgeon. I think surgery is very helpful for many women, but believe it or not, there are some patients that come in here and I listen to their history and I'm like, well, maybe we should try some other things. Maybe we should try this less invasive treatment first, or we should go this way. I don't always recommend surgery right off the bat. However, when a patient comes in and tells me I have a family history of endometriosis, I have painful periods. I have since I started my period as a young girl. I have a sharp stabbing pain when I have a bowel movement. When my bladder is full, it hurts. I can't have intercourse with my spouse because I have pain. I have pain during intercourse. I have pain after intercourse. I have trouble getting pregnant. She literally hits every symptom, and she's never been talked to about endometriosis. Sometimes just given options for medications like birth control, but nobody's really sat down and talked to her about this diagnosis or why she may have the diagnosis. Diagnostic delays can also be present because women frequently are sent to other specialists. They're like, oh, you have bladder symptoms, go see a urologist. You have GI symptoms, pain with bowel movements, why don't you see a GI doctor? And so frequently these symptoms that can all be related to the same thing kind of get pushed off, especially if you don't know what to do. Doctors are not perfect. We can't know everything about everything, but it is important to just listen to your patients, listen and believe them. I joke that my job is actually very easy. I sit here for a 45-minute visit and I listen to your symptoms and I believe them. And then we decide together what the next best steps are. But it's really not rocket science. It's quite incredible what my patients have been through, what they've persevered through, what they've accomplished with all of this disease in their bodies, and also how they've had to continue to advocate for themselves to get to me, to get to treatment, to get to pelvic floor physical therapy, to find somebody that listens to them. And I am always so impressed with them before, our treatment plan, so impressed with them afterwards. And sometimes, we have to keep going. This endometriosis treatment is unfortunately a lifelong endeavor. We have to work together and make sure that we're truly, decreasing that inflammation so that we have our best outcome. It's a marathon, but working together is truly an honor. So I have a story about a patient who came to see me. I don't know. And this is about a month ago now. And she sat in my office and she was talking to me about her bladder and bowel symptoms. And she's like, I feel like I have to urinate all the time, but it gets a lot worse around my cycle. My bladder is full. It's pain when it's full. And also as I'm moving, through my cycle, I notice that I kind of have alternating diarrhea and constipation. But during my cycle specifically, it hurts so much to have a bowel movement. Sometimes I have a hard time sitting on the toilet. She's like, but my doctors have told me it's probably stress. I'm under a lot of stress at work. My family life is also very stressful. And then we went to surgery now probably 2 weeks ago and confirmed that it's endometriosis. So yes, stress can affect us physically in so many ways, but sometimes you have to look outside of just the emotional factors, stress, anxiety. A lot of times there's an underlying physical etiology of your endometriosis. So you are not crazy and you are not alone. There are real reasons these symptoms get overlooked, and it is very important to speak up, but also to find the links to understand that this is very much a whole body disease. All right, so let me go back into the into the chat now and see if I can answer a few more questions for you guys. I really appreciate you sticking with me for this last hour. I love talking about endo. And like I said, I can get off on tangents, so I apologize. I got to rein it back in sometimes to really talk about some of the etiologies. So this woman said, I'm the first in my family to have endometriosis, and I'm still questioning why. And let me just tell you, you're not alone. Many women I see have no familial history. So they don't meet that genetic component, but you're not alone. Just like in breast cancer, most women with breast cancer actually don't have the hereditary genes. Similar with endometriosis, most women with endometriosis do not have this hereditary component. However, when you do have a familial component and you do have all of these symptoms, usually your endometriosis is a little bit more advanced or a little bit more aggressive subtype. So you may have a greater stage disease than somebody else with similar symptoms. And I see that you're questioning why, and that is a good question. We don't know why, and that's one of the reasons why endometriosis is so difficult. So we talked about, the benign metastasis through the lymphatics and the lymphatic channels. I believe more of like the malaria. It's called Malarianosis theory. So ultimately, it's the Malarian etiology or origin of your endometriosis. So this is the one that I use more frequently, but it's likely a combination of some of these, like the Malarian etiology, the benign metastasis. There may be some bone marrow changes as well. But the Malarianos theory is that these cells implant even when you're in utero. So they don't migrate where they're supposed to. They are very similar to the lining of the uterus, but like I talked about before, these cells are not the same. They're expressing different genes, they're expressing different components. And so this but I do think that likely these cells implant well before you have your first cycle and your body starts making estrogen. And then as your body starts to make estrogen, you start to be more symptomatic. And some women are symptomatic from the very first period. Some people are symptomatic later. There's also a theory that talks about like peritoneal mesothelial lining. So that's a lining in our pelvis that kind of covers all of the area. And there's a theory that it could transform into some of this endometrial-like tissue. That one's a little bit more difficult for me to grasp. I think the Malarian theory is a little bit more realistic on how these cells implant, but I also do sometimes see this lymphatic spread, so the benign metastasis through the lymph systems. And then there's also a discussion of stem cells, so bone marrow stem cells that they can turn into any cells imaginable. And you all know about stem cells. They help regrow joints and tissues, so they circulate in the blood. They can reach these areas indirectly, and then if they find a favorable environment to grow, maybe that's how they start to change. And so it's probably, like I said, a combination of all of these, because these theories differ between individuals. You'll talk to different endometriosis experts, and different endometriosis experts even throughout the country or other countries, they may have a slightly different ideology of how endometriosis comes around. And we do have molecular evidence to support most of these theories here, not the retrograde menstruation, like I mentioned, that's been debunked, but these other theories that have more science background. We just don't know which one it is, but it's likely a combination to varying degrees of overlapping of how the endometriosis is working. And how it implants. All right, I'm going to go down to a few more questions. Okay. All right, let's see. All right, so this woman asked about migraines with her headaches and why sometimes we have these inflammatory responses. So hormonal migraines and hormonal headaches can be multifactorial for sure. They are more common in women with endometriosis because you do have this inflammatory response. When you have your cycle, you have more circulating cytokines, more circulating inflammatory markers. If you were to check a woman with endometriosis throughout her cycle or throughout the years, you would see these bumps in the inflammation. And some of it's you can see through bloating. When your body is more bloated, when you have more pain, your body can also hold on to fluid. But sometimes we also see these migraines, and the migraines are multifactorial. One is this chronic rise in inflammation. Another one is these dramatic change in hormones. So, right, if you're not on any type of birth control, natural hormonal cycle, right before your period, your body realizes it's not pregnant. These hormones are very high. They've just peaked through ovulation, and they're more elevated than they are at baseline. And the day before your period, they literally crash to the floor. So they go from the top of the mountain down to the valley, and that's a big change for your body. And sometimes when you have these changes, some of it is related to fluid fluctuation, some of it's related to that inflammation, and then some of it's related to these hormone changes. But they can be quite debilitating. I mean, when you're expecting a migraine that lasts for a few days every month, it's hard to plan your life around that. Okay. So I recognize Reese. She said, discuss your thoughts on birth control for adenomyosis and endometriosis. So endometriosis is, like I mentioned before, it really doesn't follow the rules. It also has an aromatase property to where it can make estrogen out of some of the other hormones in your body. So if you were looking at a cell that lines the endometrium and a cell that is endometriosis in the pelvis, you can see that they have higher aromatase properties. And so these aromatase properties are can convert other hormones into estrogen. So ultimately, endometriosis can make its own estrogen. That's why sometimes the hormones don't work well to sort of help subdue the endometriosis. So they do not make the endometriosis. Birth control pills do not help the endometriosis go away, but the progesterone component of the birth control pills can try to help subdue the endometriosis. However, not all endometriosis responds to hormones, and some of that is because of these aromatase factors. In theory, it should, but it doesn't always. Endometriosis doesn't follow the rules. However, adenomyosis, which is the first time I brought this up. So real quickly, adenomyosis is inflammation of the uterus. The uterine lining grows into the muscle wall. Adenomyosis, the uterus is heavy, kind of boggy, swollen. Symptoms of adenomyosis are heavy bleeding, prolonged bleeding, pain that radiates to your back, pain down your legs, pain during your cycle. That is adenomyosis. These cells in the uterus actually do respond very well to progesterones, whereas endometriosis does not. So adenomyosis is treated with progesterones, typically Mirena IUD, birth control pills, progesterone only pills, or a hysterectomy. So hysterectomy is not a treatment for endometriosis, but it can be a treatment for adenomyosis because it helps subdue these cells in the uterus. One, so the adenomyosis does not continue to progress and get worse, but also so that it can decrease the amount of bleeding and therefore the inflammation that the uterus is extending during this cycle. So adenomyosis tends to be more pain during the cycle. All right, so there's more people talking about how long it took them. This one said 20 years. This one said 15 years. How many years that it took them to to have endometriosis, and how to finally get their diagnosis and their treatment. And it's so important, like I said, to advocate for yourself and try to find treatment and try to find answers. And sometimes you are your own best advocate, talking to doctors, trying to find somebody that's going to listen to you, somebody that's going to understand what you're going through. So lastly, I want to talk about what this means for your body and your options. So one misconception is there are no real solutions until I get surgery. And so that is actually not true. So to understand the biology, how this inflammation also is affecting the endometriosis can help you make more informed choices and informed decisions. No pelvic floor physical therapy, diet changes, acupuncture, lifestyle, all of these things can help decrease those circulating cytokines, those cells that are causing more inflammation, these T cells that are fighting the immune response. So treating your body holistically does help with endometriosis. And no, it does not make the underlying endometriosis lesions go away, but it may help with some of the systematic inflammation that it's expelling. Surgery truly, unfortunately, at this point is the only way that we know to go in and to remove the disease, to treat the underlying etiology. But these other lifestyle, changes should not be ignored because they are just as important and they can give you relief and benefit in the long run. I do have a few patients that have decided against surgery and they're performing lifestyle, strict diet changes, exercise, pelvic floor physical therapy. Some of them are on hormones. And maybe they'll need surgery in the future, but if their pain is controlled and they're helping to manage that inflammation and they know their body, you need to listen to it and listen to yourself. So like I mentioned, I have patients that don't go straight for surgery, that we talk about lifestyle management, what next steps are. We try, truly a multidisciplinary approach. And when we use all of these at the same time, attacking the endometriosis from different areas, we do see more of a benefit and longevity from endometriosis. So surgery is not an end all be all. A lot of times we still need to continue to treat the damage that the endometriosis has caused, then let the nerves rejuvenate. Sometimes tissue remodeling takes up to a year after surgery for those nerves to calm down, the healthy tissue to regrow in those areas. And then your body has to relearn how not to be in pain. So trying to reset some of those nerve receptors so that central sensitization of pain can downregulate. So knowledge is power. When you understand what's happening in your body, you can take action, and it is imperative. And I see this in my patients all the time. And again, I am so impressed with them. They just take the reins, and they have done this. Many women throughout their journey of endometriosis, they have had to take the reins, educate themselves, learn about endometriosis, getting that knowledge so that they have the tools to understand what next best steps are for them. Because endometriosis is very much not a one size fits all. This is an individualized approach to endometriosis treatment because people have different goals. They have different medical history. They have different desires in their future. Some women, they have different symptoms. Some women are more bowel based or bladder, or their goal is fertility. Everybody is different. So it is very important to treat a patient individually, understanding their goals, understanding what they need, what works for them, what doesn't work for them, what have they tried in the past, listening. Again, just using my ears more than my voice sometimes is the most powerful tool that I have. All right, so I'm going to go through just a few more questions here, and then I think we'll finish up. So some women talk about, nerve pain after endometriosis surgery. And this can happen. Endometriosis causes chronic nerve damage, nerve pain, and so, like I said, sometimes it takes a full year for tissue remodeling. Sometimes these nerves respond to injections to try to help them reset that central sensitization of pain. All the nerve knows is to be in pain. Send pain receptors. And so sometimes helping them reset with rather a lidocaine or steroid injection, or just helping to decrease the stress around them, can be very beneficial. But if you had surgery and you're still feeling some of those nerve pains, do not give up. That's when we can implement some of this multidisciplinary approach. Sometimes I even have you see doctors that kind of specialize in nerve management. Dr. Kapadia is an excellent resource here in DFW, and she really focuses. She's a physiatrist, so she really focuses on the whole pelvis and kind of nerve mapping, how she can help down regulate some of the nerves and the muscles to try to get you to your ultimate goal. So someone mentioned, is there something I can do to eliminate ovarian cancer as a differential diagnosis? So endometriosis does slightly increase your risk of ovarian cancer. So ovarian cancer is 1 in 70 women. And the reason it increases your risk is because of this chronic inflammation. So you have chronic inflammation, anything living in a chronic environment has a higher risk for cancer, just like smoking, can affect lungs. The lungs are chronically inflamed, higher risk of lung cancer. Similar to endometriosis. However, this is very low risk. Your biggest risk factor for ovarian cancer is age. This is not absolute. There are young women that get diagnosed with, ovarian cancer, but that is your biggest risk factor. So usually this is affecting postmenopausal women. There are not good lab tests to differentiate these ovarian cancer and endometriosis in young women because the CA-125, these other tests usually are quite elevated in women with endometriosis. There is if you have a cyst, you can get like an OVA1, which is a more detailed screening test. But honestly, surgery is the best way to know. You go in and you look and you see the disease, you take biopsies, you send it to pathology. Pathology can help you confirm what's going on in your body, and it's the only true pathologic way. You can do a CT scan guided biopsy, but usually they have to see lymph nodes or something solid to be able to biopsy, and that's when cancer would be more advanced. So endometriosis surgery actually is your best way to help try to avoid additional procedures, but to get answers in that way. Let's see. Just going back through some of the messages again. Thank you guys for for listening to me for the last hour and listening to me kind of go through endometriosis and some of the genetics behind endometriosis. And now we have at least an idea of where endometriosis comes from and why your symptoms haven't been taken seriously. There's a myriad of symptoms that are likely all connected to endometriosis: fatigue, endometriosis, pelvic pain, headaches, GI symptoms, bladder symptoms, fertility. A lot of these are all related to the endometriosis because it is very much a whole body disease. But knowing what's happening and knowing what to do next are two different things. So you understand now what's going on in your body, why you're having this chronic inflammation, maybe where the etiology of the endometriosis is coming from. But now we need to plan what can we do next. So can I take just a few minutes to show you a guided way to move forward with expert support? So here at Endometriosis Center of Excellence, I do try very hard to implement a multidisciplinary approach. I feel like this is imperative to long-lasting and better outcomes. Yes, I'm a surgeon. I see the benefits of surgery. I see excellent benefits from surgery, both from a pelvic pain perspective and a fertility perspective. But if we don't treat your body as a whole, a lot of times we're floundering. And many of my patients see benefits. There are some patients that continue to have pelvic pain, and we fight with them. We find treatment plans for them. We keep working with them to find what next best steps are. But everybody is different, and that's again why endometriosis treatment is not a one-size-fits-all. This should be an individualized plan, understanding your goals and your symptoms, and creating this together. I'm not telling you what to do. We're deciding together what to do. And that's when we see the most benefit. So click on the link in the chat. Come see me. We'll get a comprehensive evaluation at the Endometriosis Center of Excellence. We'll go through this together and decide what next best steps are. I would be honored to see you. My patients are truly rock stars, and I'm so impressed with them. And we have a long way to go with learning more, about endometriosis and some of the etiologies and the background of it, but we're getting there. And I hope throughout my career we can find more answers and more treatment plans outside of just hormonal management and surgery, so that there's some better options out there. But right now, we're working with the tools that we have. So a few more questions from the chat. Can anything help me if I've already tried everything? And I think that is really important to come in and just get a full evaluation. Start from the very beginning. What have you tried? What have you not tried? Did you do it appropriately? Were you were somebody that was skilled? Did you have excision or ablation surgery? Was your pelvic floor physical therapist understanding kind of your goals? What diets do you have? Have you met with a dietitian? What are you doing for exercise? How are you treating your body as a whole? How are you mentally with all of this pain and all of this fatigue? How are you coping? But really, I think it's important to get a really comprehensive evaluation and exam as to kind of what would be next. Can endometriosis really cause gut issues or fatigue? Absolutely. So the most common symptom of endometriosis is fatigue, and we talked about that, why your body is chronically fighting this inflammation, giving you very little energy for your daily functioning. Gut issues, endometriosis, even if it's not on the colon, and we go in for surgery, sometimes it's not even on the colon or the rectum, but you still have bowel symptoms, chronic constipation, knives shooting when you're having bowel movements. That's likely affecting the uterosacral ligaments, as those have to stretch with defecation or with intercourse. Same thing, they both have to stretch. And those are right near your hypogastric nerve. So the hypogastric nerves frequently give you that nerve sensation of sharp stabbing, burning pain, but it also can slow the peristalsis of the colon. So women with endometriosis frequently have this alternating diarrhea and constipation, or more related to constipation, kind of depending, but it's very common to have both GI and gut symptoms as well as fatigue. So guys, I'm going to put the booking link here in the chat as well. Our spots are limited. I would love to see you. They are filling up fast. Again, I'm so honored that there are so many patients and women that are that are wanting to see me, and here we go, wanting to see me and get help for endometriosis. You guys are truly the ones advocating for yourselves and advocating for each other, and it is so cool to see. I've sort of watched this transpire over my career with the last 5-10 years, and you can really see how women are starting to support each other in this endometriosis space, whether it's finding doctors that listen to them or finding treatment plans or just supporting each other, knowing that they're not alone is very cool to see. So I would love to meet with you in the office and start this comprehensive plan and treatment for endometriosis. You can click the link here to meet with Cyrus. Cyrus is my she answers my phone, and she's excellent, and she'll be able to kind of walk you through the scheduling process to get an appointment scheduled with me. But I'm honored that all of you came today and appreciate you sticking with me. Somebody said they weren't able to book appointment until July 2027. That is incorrect. So I will work on that and see if I can get you guys a better time and make sure that it's open so that you can get in to see me. But also, if the link isn't working, please feel free to call me. Oh, here's a good one. Primary care physician. They are the best. Yes, you're right. So, we have a lot of specialists that do understand endometriosis, and it's great when you find one that listens and is able to help you and sort of understand your pain. But you're right. Physiatrist, PM&R doctors, those are the ones we use, for nerve pain and nerve management. But again, thank you guys for sticking with me for the last hour. Click on the link to schedule an appointment with me. I look forward to meeting with you and learning about you and seeing how we can help. I hope everyone enjoys the rest of their Tuesday, and yeah, just keep advocating for yourself and learning more. Remember, knowledge is power, and I look forward to seeing you guys in the office sometime soon. Y'all have a good day. Bye-bye.